Now, we will discuss the questions related to heart failure. We'll start with a case study. A 50-year-old man presented with shortness of breath for 4 months now progressed to an extent that he was unable to perform his daily activities. He often woke up from sleep due to difficulty in breathing. His medical history was significant for hypertension, dyslipidemia, diabetes mellitus, and a history of bypass surgery 3 years ago. He is on aspirin, atorvastatin, amlodipine, and metformin. No significant social or family history was noted. His vital signs were stable. Physical examination showed bilateral diffuse crackles in lungs, elevated JVP, and pitching edema in lower limbs was present. ECG showed normal sinus rhythm with left ventricular hypertrophy. Chest X-ray showed vascular congestion. Laboratory results showed a pro-BNP level of 874 picograms per ml. Echo showed systolic dysfunction and an ejection fraction of 33%. So based on all this, the most probable diagnosis is heart failure. But we will look at the case again. The duration of symptoms is for 4 months, which means that it is a chronic heart failure. And they have given that the person is unable to perform his daily activities and is unable to sleep because of dyspnea, which is orthopnea. So this is suggestive of involving the lungs. And this is also evident where you can see crackles in your RS examination, and you can also see that it shows the left ventricular involvement with hypertrophy, pulmonary congestion. So therefore, it is a type of a left ventricular failure. What is the intensity of your heart failure? So this, you can see BNP levels are 874 picograms per ml, which is closer to 900. So therefore, this is a moderate heart failure. And when we discuss about whether it is systolic or diastolic dysfunction, they have given ejection fraction is less than 33%. So therefore, it is systolic dysfunction. So it is basically a chronic heart failure involving the left ventricles, moderate in intensity, and it has got systolic dysfunction. So this is your answer. Next question is, which of the following statements is true regarding measurement of plasma brain natriuretic peptide to diagnose heart failure? An elevated plasma BNP in a dyspneic patient confirms the diagnosis of left heart failure. In the presence of renal failure, BNP levels are suppressed even when heart failure is present. Plasma BNP levels may be falsely low in patients with obesity and heart failure. Serial measurements of BNP in the therapy of decompensated heart failure should be used to guide therapy. Finally, all of the above are true. So, BNP level gets elevated whether it is right or left ventricular failure or biventricular, it is going to be elevated. So, it is not specific for left heart failure. So, it is ruled out. And when we discussed BNP levels, I told you it also falsely increases in renal failure. So, in people with renal failure, the levels should increase. But here they have given suppress. So, this is also ruled out. BNP levels are falsely low in patients with obesity. Yes, I told you in obesity it is falsely low. So, this is right. But the next option, BNP levels, though it is an important prognostic marker, a treatment is not only planned based on BNP levels. So, therefore, this answer is wrong. So, the right option over here is your option C. The next question is, a 68-year-old man with a history of myocardial infarction and congestive heart failure is comfortable at rest. However, when walking to his car, he develops dyspnea, fatigue, and sometimes palpitations. He must rest for several minutes before these symptoms resolve. His New York Heart Association classification is which of the following? It is not class 4 because it is given the person is comfortable at rest. So, it is not class 4. So, class 1 is where there is no limitation of activity, but here there is limitation of activity. But when the limitation is going to be less than ordinary activity is class 3, when it is ordinary activities it is 2. Now here the person is unable to perform even less than ordinary activity because the person have to take rest even to perform that. So therefore this belongs to class 3 of your NIHA classification. The next question, the husband of a 68-year-old woman with congestive heart failure is concerned because his wife appears to stop breathing for periods of time when she sleeps. He has noticed that she stops breathing for approximately 10 seconds and then follows this with a similar period of hyperventilation. This does not wake her from sleep. She does not snore. She feels well rested in the morning but is very dyspneic with even mild activity. What is your next step in management? EEG has got no role in the patient with this type of compliance. Maximize heart failure management, nasal continuous positive airway pressure during sleep, obtain a sleep study, prescribe bronchodilators. Now with these patients, the history is suggestive of the person having Cheney-Stokes respiration. So the person has got Cheney-Stokes breathing. So when this is going to disturb the sleep, when it is obstructive sleep apnea, then there is a purpose in giving this. But otherwise there is no use in giving this because the person's sleep is not disturbed. They have given this does not wake her from sleep. So there is no role of giving CPAP. Obtain a sleep study. Already the history is clearly given by husband, so we don't have to perform a sleep study. Bronchodilators, the problem is not with the bronchus, so bronchodilators are not going to help. Now maximize heart failure management. Whenever a person develops Cheney-Stokes breathing, it means that the heart failure is progressing. So the person is getting into the severity of heart failure. So therefore, in this person, you have to maximize the heart failure management. So the drugs have to be intensified. So this completes the discussion on heart failure.